I'll take you through what angle closure disease currently is and what are the problems that we face. We know glaucoma is a global problem, and if you look at the recent projections, by 2040 we will have almost 112 million people with this disease. And some of these patients are going to be angle closure glaucoma. The chart that shows you roughly the distribution, and you can see that angle closure is a significant proportion, even though there are regional and ethnic variations. But in our part of this world and in the Asian countries, the ACG happens to be a significant problem. So it's important to know this, and it's also important to know about angle closure diseases because it's more blinding condition as compared to POAG. And if you look at the projections from the Singapore study on Chinese population, is about 3 times more blinding in this population as compared to POAG. In India, Dr. Vinay has already told you the statistics, but in general it is believed, there are some variation in different studies, but generally it is believed that half of our patients are angle closure glaucoma patients. So we have a fair share of angle closure disease in our country. Now the problem when we talk about angle closure is that there are many gray areas and there are many things which are not clear, and one of the problems that was always there was the unclear terminology and the definition itself. Angle closure disease has been referred variously as angle closure disease, angle closure glaucoma, narrow angle glaucoma, and there are many stage-specific terminologies that have been used, and they have been quite confusing actually. But fortunately now we have what we call an ISGEO classification, and that was proposed in 2001 and published in 2002, and that kind of tries to simplify this problem. So as per this classification, now this is actually more widely accepted and followed classification. So this tries to differentiate between the PSCG and PSC and PSCS, that basically because the way we define glaucoma is that you have to have end organ damage like optic neuropathy. So people who have optic neuropathy, they are the PSCG, and others are people who have a risk, and they could be the PSCS or PSC. So you could have the details classification in BJO in 2002. This is a good classification, as I said, it's kind of more accepted now, but still it's not without problems, and people say it's basically good for surveys because clinically what we see is far more complex a spectrum, and that is not really covered by this classification, but still is a very good beginning and good place. The other problem is the mechanism of angle closure glaucoma is still not very well understood, and there are a number of mechanisms have been proposed: the pupillary block, non-pupillary block, iris crowding, plateau iris, small globe, big lens. Choroidal expansion and effusion have been recently more kind of attracted, and you have the aqueous misdirection in some of these patients. Now, pupillary block probably is the most common mechanism and a little better understood mechanism, all of these, and it's not that one patient will have only one mechanism. There could be multiple mechanisms playing a role in the same patient. So from therapy point of view, it is very important to understand that what mechanism angle closure is, and because that has a bearing on the treatment that we are going to prescribe to the patients. The other issue is that we don't have a screening test for angle closure disease, and majority of the cases are asymptomatic. Now this is again a bit counterintuitive because our textbooks still correlate or associate angle closure disease with acute angle closure or acute rise in pressure. So that has to be kind of delinked, and we know that angle closure disease actually is a silent disease. In majority, there are very few people who will present with acute angle closure glaucoma, and there is unfortunately no reliable screening or probabilistic tests that can be advocated for all. So as a result, this is a very asymptomatic and mostly underdiagnosed condition. All glaucomas are underdiagnosed, and PACG particularly is more prone to misdiagnosis. So question is, how do we diagnose glaucoma, angle closure disease? Diagnosis is basically clinical, and it's based on 2 factors. One is the recognition of the occluded or occludable angles, and second is the recognition of the optic nerve damage. So these 2 things are very important to diagnose angle closure disease. And how do we diagnose them? Because to do this, you need a very peculiar set of clinical skills, and which includes skills to assess the anterior chamber depth on flashlight or preferably on a slit lamp, and gonioscopy, then also optic disc evaluation and tonometry. So for angle closure disease, you need a little additional set of skills than for POAG. Gonioscopy is actually very important and is indispensable for any form of glaucoma, actually, not only angle closure, because without gonioscopy you can't really say whether there's an angle closure or open angle glaucoma you are dealing with. So when you are doing gonioscopy, we kind of determine how much the iridocorneal contact is and whether this contact is synechial or it is, or non-synechial angle closure. However, the gonioscopy itself has some issues. This is a clinical skill and it needs experience and there's a learning curve. And it's also a little bit uncomfortable to the patients and quite subjective in its interpretation. So, but the biggest problem with gonioscopy as of now is that there is no one uniformly accepted grading system. There are a number of ways to depict changes. I have mentioned 3, like Sheffer-Shees or space classification, but there are many more. And so when we talk about gonioscopy, we are actually talking very different languages, which many people may not understand. So that's the biggest problem, and there's an urgent need actually to have some common platform or some common form of grading which can be understood by most people. Recently, the imaging for angle closure has become a little more prevalent and more kind of promising. And in this context, it's important to understand the relationship between the angle, the peripheral cornea, the root of the iris, the ciliary body, and the anterior lens surface of the iris. But these structures are very important because it's their interplay which determines how the angle behaves, and this there where the pathogenesis of the angle closure actually lies. And UBM is perhaps the best mode to study these because that has a very good penetration and good resolution to give you a relationship. But the problem with UBM is that it's kind of tends to be invasive and takes more practice. You need a dedicated person to do it and a very costly equipment, and it's not suitable for mass screening. So we have anterior segment OCT and pentacam and ICAM, and there are some other methods which are being used, but all these have the limitations that don't actually penetrate beyond iris. So they can give you some idea of the peripheral recess of the angle, the cornea and the anterior surface of the iris, but nothing more than that. But some of them, particularly OCT, because they're non-contact in nature, so they have some potential to act as a screening tool, but they have not reached that point yet. The advantage of imaging is that it's objective, and you can use software to manipulate the data, and that can give you a number of parameters which can be objectively compared from one examination to other and over a follow-up time. So it's very useful for follow-up. And also these investigations, like particularly UVM, gives us the mechanism of angle closure, like this patient who have an angle closure, but this is because the UV diffusion that is there. So it's called a secondary angle closure rather than primary angle closure. The gonioscopy will not give you this information. So what is the best method for assessing angles? Gonioscopy still remains the best method, more clinically useful, and other methods supplement gonioscopy. They do not as of now replace it. So other thing we have to know about this is who is at risk of developing angle closure. So people who are more than 40 years of age, female gender, shorter axial length, shallow anterior chamber, and there might be some genetic factors which are predisposing. So these people have to be kind of opportunistically screened whenever you get a chance to see this patient in the clinic. Make sure that you screen them for angle closure glaucoma. Now, the management basically involved ascertaining the mechanism of angle closure, and this is essential for its management. And it should be used in conjunction with the stage of the disease, or there's classification of disease on gonioscopy and other parameters. As I said, the pupillary block is the most common mechanism, and there the laser peripheral iridotomy is very helpful. And you can, a small hole in the iris can actually relieve the pupillary block, and it could be therapeutic in many cases. And that can be, there is ample evidence to suggest that it works. And if there's an acute angle closure glaucoma, then iridotomy might have to be preceded with the medical treatment to control intraocular pressure, and then do laser iridotomy possible, or iridoplastic. However, we should never forget the other eye, because the other eye is also at risk, and that should undergo prophylactic laser iridotomy. So role of LPI is very well established in angle closure glaucoma, and it's believed that all these patients of angle closure glaucoma, they have some element of pupillary block. So laser iridotomy is practically needed for all angle closure glaucoma, angle closure or angle closure glaucoma patients. And the role of medical treatment is there. It could be before laser iridotomy or after laser iridotomy. It is possible to control intraocular pressure with medicines alone in angle closure glaucoma, but that's not that's not a substitute for laser iridotomy, because that doesn't remove the risk factor. So medical treatment is required, but it should not be used as a substitute for laser iridotomy. And then we have to know that laser iodotomy may not work in all patients, and there will be some cases like non-pupillary block mechanism patients where laser LI may not going to work. And this is a patient of plateau iris syndrome where LI did not work, but we could open the angle later on after doing a peripheral laser iodoplasty. And some of these patients we have, maybe the lens may be the culprit, and this area is still evolving, so the role of lens extraction or role of lens in causing angle closure glaucoma has been recently attracting more attention, but we still are not very clear its role. But there are certainly some patients where if you have a little bit of cataract on and there's a large lens, shallow AC, and the removing early cataract surgery does help deepen the anterior chamber, as you can see in these patients. But this part is still a bit controversial and evolving. And of course, we have glaucoma surgery, but we have to remember that when we are doing glaucoma surgery for angle closure disease, there's a little higher risk of complications, and we have to be prepared and prepare the patient to accept that. Sometimes the question asked is that should we treat the PACS patient? No, because who is to be treated? Now, basically, all angle closure glaucoma, all angle closure PSC and PSCG needs to be treated. What about PACS? Because if you treat PACS, it could be actually prophylactic. The problem here is that the logistics, economics, and there are statistical reasons that this is not really warranted, because the number needed to treat is really high to prevent one angle closure, because the risk of conversion for PSC to PSCG is quite low, and in between there's a one stage of PSC which actually gives you an opportunity to intervene if PSC really gets converted into PSCS really gets converted into PSC or PSCG. So to summarize, angle closure is a significant health problem globally and also in India. Is a grossly underdiagnosed and misdiagnosed condition. There are many gray areas in its understanding, classification, and documentation. And the diagnosis is purely clinical. It needs a specific set of skills which must be taught and learned. And there are a number of treatment options available. And laser iodotomy plays a very important role in management of angle closure disease. Thank you.